Thank you, Erica. Thank you for joining us. I'm Dr. Dean Seidlinger, Health Officer and State Epidemiologist at the Oregon Health Authority. I'm here today to provide an update on monkeypox, or HMPXV, in Oregon, and our local and state response to the outbreak, including the latest on cases and distribution of vaccines for preventing the virus, how we're reporting data on monkeypox cases and vaccinations, and sharing other important information, what we know about who's most at risk for the virus, and what you can do to protect yourself and those in your community. First, my thoughts are with all those who become ill with this virus. While for some, the course is mild, that is not true for everyone. Many people have had severe pain and other symptoms requiring greater care. Also, I want to acknowledge the uncertainty and anxiety that the monkeypox outbreak brings as we continue to manage the COVID-19 pandemic, even as reports of COVID-19 cases, deaths, and hospitalizations have slowed significantly since the peak of our Omicron surge at the start of the year. Over the last 2.5 years, we have had our lives and livelihoods turned upside down as we dealt with surge after surge that challenged us to follow recommended and required protective measures, getting vaccinated, mask wearing, keeping our distance from others, avoiding crowded places and travel, and seeing businesses, schools, and other public places close or limit their operations. It might seem like too much to now have to experience an outbreak of yet another infectious disease as we continue the long, slow recovery from COVID-19. I know this causes worry for many people in Oregon, and it's difficult to think that it may once again alter how we go about our daily lives. The good news, and we will provide more about this detail shortly, is that although monkeypox is a serious public health concern and it is highly infectious in certain situations, it's not another COVID-19. Monkeypox does not spread the same way between people, and is therefore not as easy to catch as COVID-19. The number of cases amongst individuals who have close, intimate contact with someone who has monkeypox is increasing, but we are not seeing, nor do we anticipate, the same rapid spread of the virus that we experienced with COVID-19. And fortunately, there have been no deaths from monkeypox in Oregon or other U.S. states. We are also not recommending vaccine of the general population, but only amongst those most at risk for infection and serious illness based on their likelihood of having the type of close contact with individuals sick with monkeypox. Right now, in Oregon and other states, most cases of monkeypox have been diagnosed in gay and bisexual men or other men who have sex with men. While this disease spreads not just among men, and one's sexual orientation doesn't make one more susceptible to the virus is circulating at higher levels amongst those communities and social groups. We can all take steps to protect ourselves and community members by changing our behaviors now at a time when monkeypox is circulating. I also want to provide an update on how OHA will be reporting data on cases and vaccine distribution moving forward. Since OHA started reporting Oregon's first few cases of monkeypox, it has been publishing data on one of its diseases A to Z pages under orthopox, which is the family where monkeypox sits. It was used for sharing disease information such as reporting requirements, investigative guidelines, and data. The pages have useful information, but they're geared towards an audience that includes county public health departments, laboratories, and clinicians, and weren't the most user-friendly for the public. Today, we have launched a new page devoted to monkeypox, or HMPXV, that can be found at oregon.gov/OHA/PH/monkeypox. It's easier to view and use, has more accessible information on who's at risk for monkeypox and how they can access testing, vaccines, and treatments, and take additional steps to protect themselves and others. It has links to additional resources, including guidance on isolation, what to do if you've been exposed, answers to frequently asked questions. It's also where OHA will begin its new cadence of reporting data on a weekly basis, typically on Wednesdays, on monkeypox cases and allocation, distribution, and administration of vaccines, which will be accessible through interactive data dashboards that will come online in the next couple of weeks. We will also continue to refine the information on this website and add additional resources. We hope this new monkeypox site can make it easier to understand their risk and what people can do to stay healthy, and how the state and our partners are responding to this outbreak. Finally, before I provide an update on monkeypox cases and vaccinations, I want to share that Oregon has just eliminated a potential cost barrier for people at higher risk of monkeypox infection who may need vaccination. On Friday, August 5th, Public Health Director Rachel Banks signed a determination formally declaring a monkeypox outbreak in Oregon, and that the cost of administration of vaccines for monkeypox shall be covered by insurers for their enrollees. This is an important step to ensure that no one will be refused vaccine if they cannot pay or do not have insurance coverage. The Oregon Department of Consumer and Business Services has issued a bulletin further detailing the new requirements for health insurers on its website. A link to the bulletin will be available at OHA's new monkeypox website. So now, let me give you an update on the monkeypox situation in Oregon. As of this morning, there are 95 presumptive and confirmed cases of monkeypox in Oregon, including 92 men and 3 women, with illnesses ranging in onset from June 7th to August 5th. We see cases across 7 counties, 3 in Clackamas, 1 in Columbia, 1 in Coos, 17 in Lane, 1 in Marion, 57 in Multnomah, and 15 in Washington. About 28.4% of cases identify as Hispanic or Latino, so cases are overly represented in this group compared to the general population. Nationwide, according to the Centers for Disease Control and Prevention, there are about 9,500 cases across 49 states, the District of Columbia, and Puerto Rico. They are amongst 31,800 cases in 89 countries as part of this outbreak. In Oregon, our data mirror national data and show that cisgender men and non-binary people are affected by monkeypox more than cisgender women. While most identify as gay or queer and report close contact with people assigned male at birth, some cases identify as straight and report close contact with people assigned female at birth. This means that anyone can be affected by monkeypox, and this is not a gay disease. But as I shared earlier, this is not an easy disease to catch. The most common means of person-to-person transmission is from prolonged skin-to-skin contact with a person with monkeypox, including direct contact with a rash, scabs, or body fluids. This is the type of contact that happens during sexual activity. Much less commonly, the virus can also be spread by touching objects, fabrics, and surfaces that have been used by a person with monkeypox and through contact with respiratory secretions of a person with monkeypox. These routes are much less common than skin-to-skin contact with someone who has monkeypox. However, unlike COVID-19, monkeypox doesn't spread through airborne transmission. In other words, it's not believed to linger in the space and infect other people who come into that space. So what are the symptoms to watch for? Monkeypox may start with a fever. Achiness or a sore throat, but it may also start with a rash or sores. The rash, or call 211 if you don't have one. Before the appointment, let your provider know that you think you might have monkeypox and cover any lesions you have. Ask your provider about monkeypox testing. If you have symptoms you believe to be symptoms of monkeypox, talk to your provider. Even if you're not in a high-risk category, you might deserve testing. If there is any similarity between monkeypox and COVID-19, it's that both have safe and effective vaccines. Given as early as possible after exposure and before the appearance of a rash, the monkeypox vaccine, known as Jynneos, can be used to prevent monkeypox infection, reduce how long symptoms last, or make them less severe. Unfortunately, as was the case in the early days of the COVID-19 vaccine distribution, the Jynneos vaccine is in limited supply, but the situation is improving. Oregon has distributed or is in the process of distributing more than 6,803 doses of the Jynneos vaccine and 23 courses of tecovirimat or TPOXX treatment since June 20th. According to our Alert Immunization Information System database, 2,187 Jynneos doses have been administered so far. We know that more than that have been administered, but those 2,187 doses are what's been entered into Alert thus far, which speaks to the overwhelming response partners have had to balance during this outbreak. As of today, OHA only has 35 doses left in stock, with others positioned with partners. Still, while vaccines are slowly making their way into communities that need them, supply remains limited. The first dose of vaccination starts protection, but individuals do not have all of the protection from vaccination until 2 weeks after the second dose. So it is important for people to continue taking additional precautions to protect themselves. With limited supply of vaccines, we are focusing on 2 approaches to monkeypox vaccination, including vaccinating people who have had close contact with someone with monkeypox in the prior 14 days, and vaccinating people who are more likely to have had close contact with someone with monkeypox in the past 14 days. In addition, Oregon, along with many other states and communities, has been using a strategy that prioritizes first doses to provide vaccine to as many people as possible, as quickly as possible. OHA anticipates scaling back on that approach and returning to encouraging second doses at the recommended 28 days after dose 1, and will try to provide second vaccinations for those already vaccinated within 3 months following their first dose, as vaccine supply increases in the coming weeks. For now, 28-day second doses are only recommended to be prioritized for people who are at risk for severe disease, including those who are pregnant or have immunocompromising conditions, as well as pediatric patients, which we have not had any yet here in Oregon. Those not in these groups can get second doses between 2 and 3 months after their first dose. As you'll see on our new monkeypox or HMPXV website, here's who we are recommending getting the monkeypox vaccine as soon as they can. Cisgender men, transgender women, and non-binary people who have sex with men who have had more than one anonymous sex partner, a partner who you couldn't get in touch with if you needed to, or more than one sex partner at a bathhouse, sex club, adult bookstore back room, or sex party in an area experiencing community transmission in the prior 14 days. Cisgender men, transgender women, and non-binary people who have sex with men, reside in an area experiencing community transmission, and have had a diagnosis of rectal gonorrhea, rectal chlamydia, or syphilis in the prior 3 months, or anyone who has sex with men and has sex in exchange for money, drugs, or something else of value with more than one partner in an area experiencing community transmission in the prior 14 days. These groups target individuals who participate in some of the highest risk behaviors that put them at risk for monkeypox. In addition to the vaccine, an investigational antiviral drug known as tecovirimat, or TPOXX, is available to treat people infected with monkeypox who have severe disease or are at risk for severe disease. If you're not eligible for vaccine right now, you may be in the future when we receive more vaccine from the CDC. In the meantime, we ask that you keep up to date with the facts about monkeypox from reliable sources. Fight stigma by remembering that anyone can be affected by monkeypox. Know how monkeypox is transmitted. Know the symptoms. Plan ahead if you're attending events or will be in situations where there may be close, personal, and skin-to-skin contact. Call ahead to your provider if you're experiencing symptoms and need to seek care. And finally, stay informed about monkeypox by using OHA's new monkeypox website. Now, I'd like to turn it over to Katie Cox from the Equi Institute to provide a few remarks. Katie?
Thank you, Dr. Seidlinger. Appreciate it. My name is Katie Cox. I use she and they pronouns. I'm the executive director of the Equi Institute, which is a queer and trans health access organization located in Portland. I'm hearing many of my community members express confusion and a lack of understanding around HMPXV. Because we're still learning about this virus, available information is inconsistent and unclear, leaving our community with little understanding of how they can keep themselves safe. Several people I've spoken to didn't even know there was a vaccine available or how to access one. I heard just yesterday from a community member that their friend, who is in a high-risk category and had confirmed exposures 2 weeks ago, was put on a very long wait list and ended up contracting the virus before they were able to access the vaccine. This person is now at risk of losing their housing because they can't work while they're sick. If we had funding for isolation and quarantine support, this would not be happening. The OHA and CBOs like the Acme Institute, Cascade AIDS Project, Pride Northwest, and others have been sounding the alarm, and the lack of urgency from the federal government is concerning. Would that urgency look any different if it wasn't impacting a historically marginalized community? Did we learn nothing from the AIDS epidemic? Our community is asking for broader and less stigmatizing messaging and vaccine access that isn't determined by identity, but rather assesses risk based on activity. This is a public health issue, not just a men who have sex with men issue. Anyone with skin is susceptible to this virus. We need to be focusing on risk assessment by behavior and not identity. We need to teach people how to assess for risk, understand the signs and symptoms to look for, and destigmatize asking sexual partners about their sexual or contact history and symptoms. I'm hearing straight people say they don't have to worry about it because it doesn't affect them. At this point, it is not an if, but a when it will start affecting other communities. Gay, bisexual, queer men, and trans people are not the only people engaging in skin-to-skin contact or having sex with multiple partners. Look at the World Naked Bike Ride that just happened. In fact, there are many gay, bisexual, queer men and trans people who don't engage in this type of sex at all. This type of blanket messaging is exclusionary and leaves large swaths of the community at risk. People who engage in non-traditional relationship structures, such as polyamory, or people in the kink community, swingers, people who are having sex with multiple people via dating apps, people attending festivals or raves, and sex workers, full service or not, this includes dancers, are all at high risk right now. There are all kinds of identities that make up these communities, including straight people. Information, health and risk education, and vaccine access is not widely known, even within the community the public health officials are trying to target. This is why it is absolutely vital that community-based organizations who are more nimble and tapped into various parts of community receive immediate support and resources to expand education and vaccine access. The OHA has been a strong partner of CBOs like the Acme Institute, community-based organizations, during the COVID-19 pandemic, reducing as many bureaucratic barriers as possible to ensure we were able to meet the emerging needs of our communities. While HMPXV and COVID-19 are very different viruses, we have every opportunity right now to prevent a widespread of HMPXV as long as the resources and information are prioritized. Thank you.
Thank you, Katie Cox. I think I'd like to say thank you to the Equity Institute and our other community-based organizations. We're privileged here in Oregon to have organizations that have deep roots in the community and can help us do outreach and provide services to the community. But more important, to be at the table, making the requests that they're hearing from community members, holding us accountable, and making our response better. We always have areas to improve, and I appreciate the comments and the concerns that are brought to us, and we will do better together, so thank you. Dr. Ludke, would you like to make a few remarks?
Yes, I would, and thank you, Dean, for that opportunity. As Dr. Steidlinger noted, Lane County has 17 cases as of this morning, 15 of which are confirmed, 2 of which are presumptive. And I must say, having been through my share of disease outbreaks over the last 35 years, I'm really quite heartened that this is an outbreak where we already have an FDA-approved vaccine and antivirals. That doesn't always happen with outbreaks in the past, and COVID is certainly one of those examples. So that is really nice to have, that type of resource behind us. In addition, I've been quite impressed with the overnighting of these products to us when we've needed them very quickly down here in Lane County. I don't know for certain if it's that way in the other 35 counties, but we've been very, very fortunate to have those products arrive in a timely manner. Yes, we wish there were more of them, but when we've needed them, they've arrived very quickly from OHA, and my thanks to Dr. Steidlinger and his staff for that. Of course, everything isn't perfect. We do wish that we had more vaccine and antivirals. This is a pipeline issue. The vaccines created in Denmark, and we don't make it in the United States, so we have issues of getting it here, but the supply is increasing. We also have some challenges, as was noted by Katie, with the media messaging and making sure that we have, an equitable conversation with our community in this space. And I appreciate Katie bringing that up. We're working on that down here in Lane County as well. I would also think it's worth mentioning that we've seen, some complicated wounds. And I think it's important for the media to know that this is not, in some people, one or two of these umbilicated little pimples. Some people have some really complicated wounds. They get secondary infections, and we really would like the media to help us magnify the message that if you see a strange rash, please go to your provider, and especially if it gets stranger by the day. We really want these to be evaluated quickly before you get other secondary infections like staph or strep on top of this virus. And we've seen a few of those cases. And those cases, of course, can lead to more severe infections and hospitalization. We wish to prevent those. The final point I'd like to make is with my other hat on, not the Lane County Public Health Officer, but the chair of Oregon's Health Officer Caucus, representing our local health departments. We've been working since May. We talk every 2 weeks, the health officers across the state. We've been working since May on our messaging and our response and learning from each other through the Health Officer Caucus. And our recommendations to other jurisdictions that have not yet seen a case is to make sure that they secure a few doses of the Jynneos and TPOXX. When they get a case, they can jump right on it very quickly, work on their standing orders so that their communicable Z staff are ready to respond when a case does show up in their community. Work as well on the awareness with their provider community on the specific requirements for the antivirals. Not everybody is eligible, and we need to work with our clinical community as well. And then finally, we now have several laboratories that are doing this testing. Early on, of course, it was just our state public health lab, but now some of the larger clinical laboratories across the country like Quest and LabCorp are doing that work, and they serve most of the counties in Oregon. So we're asking our local public health colleagues and health officers to work with their labs to ensure that they have the appropriate sampling supplies and shipping supplies to make sure that they can get samples quickly off to those labs to get test results. So I'm going to stop there and pitch it back to Dr. Seidlinger, and thank you for the opportunity to join all of you today.
Thank you, Dr. Lucky. I appreciate your partnership, your staff, all of our local public health partners, community-based organizations, our healthcare partners, tribal and federal public health partners, as we respond to this complex and evolving situation. This is not an OHA response. This is truly a public health system, all hands on deck response. And so we will continue to slog even with tired and exhausted staff from our last 2.5 years of COVID. And with that, Erica, we're ready for questions.
Great. All right. Thank you, everyone. Our first question comes from Shayla with the Democrat Herald. Go ahead, Shayla.
Thank you. Thank you, everyone, for being here. I had a question about isolation and how long isolation should take place after realizing you've been infected. And I also have a secondary question. I'm not sure if I should get back to that, but that's my first question.
Thank you, Shayla. I'll take that question. We don't have a specific time amount for isolation with monkeypox, but we ask people to stay isolated until their last lesion has scabbed over and that scab has come off. That's the time when we anticipate that they are no longer infectious to others. That can be as short as 2 weeks, which isn't short, or as long as 4 weeks. So that is a long time to be isolated from others. In the household, making arrangements to try and limit contact with others, keeping wounds or rashes covered as much as possible for when you are in shared spaces in the household with others. Some individuals, if they're feeling okay, have the luxury, the availability of working from home. Others do not, which is why we know and we've identified and are looking for the resources to provide support to individuals who may have to isolate for up to 4 weeks. This can be a difficult situation, particularly when you're ill. It can be very isolating as well. So yes, the isolation period, typically 2 weeks to 4 weeks until all those lesions have scabbed and come over. What was your second question, Shayla?
Thank you. My second question had to do with scarring. I'm wondering, I've been seeing kind of some stuff about scarring being an issue in the long term. I'm wondering how long scars might appear if they end up going away, the depth of scars, anything you have to offer about that information, I would appreciate it. Thank you.
Yeah, in previous cases and outbreaks with monkeypox or MPXV, we have seen scarring. So that's why wound care is a very important part of counseling the patients who have monkeypox infection. Traumatizing the lesion, so scratching it, itching it, rubbing it, may put that individual at a higher risk for scarring. And so trying to keep lesions covered, not only does that reduce your kind of chances of touching it or rubbing it, it can also reduce the chances of transmitting to others who might be in close contact with you. Sometimes taking an anti-itch medication may help because these lesions can be itchy. Putting on a barrier like a petrolatum or petroleum jelly or something else over the lesion to prevent you from scratching it can help to minimize scarring. But we know that scarring can be an issue after monkeypox. More lesions, more severe lesions lead to a higher chance of scarring. Lesions on the face for many individuals, the scarring would cause more symptoms, so paying special attention to trying to keep those covered with a lotion or other things and trying to keep from touching them. Lesions around the eyes or in the eyes can cause special problems, including blindness in individuals following. So that's why it's very important to work with your healthcare provider about having dressings and a routine for taking care of those lesions to minimize scarring, minimize secondary infection, minimize complications such as having those in the eyes.
Great questions. Thank you very much. Okay, our next question comes from Colby, and I hope I'm saying your last name correctly. Enabrad, Central Oregon Daily News. Go ahead, Colby.
Yeah, that was correct. Good job. So, as Katie Cox said, anyone with skin can contract this disease. School is coming up. Should parents be concerned? Should schools enact preventative measures? If so, what would those be?
Thank you for that. I want to reiterate that while anyone can get this infection, right now we are seeing it transmit more in social groups and community groups of gay, bisexual men who report having sex with other men because of the prolonged kind of close contact that it requires that often happens during sex. We haven't seen a lot of spread into other communities. But as Katie Cox said, it's not a question of when, it's a question of if. That same reasoning could hold true with children. Adolescents, older children who participate in these types of close, intimate, or sexual contacts, if they have that contact with someone with monkeypox, could come down with monkeypox. Younger children or any children who are cared for by a parent or caregiver in a household who has monkeypox, that transmission could occur. And we worry especially about younger kids who require more close contact with their parent or caregiver. And some parents who are sick, don't have an alternative caregiver, don't have someone else who can take over that duty for caring for the youngest child. So we are having discussions with our Oregon Department of Education colleagues, but we don't anticipate that schools will be a location where monkeypox transmits commonly. But we do anticipate that whether it's a staff member or a student, schools will have to face issues where someone with monkeypox may have been on campus. What would put individuals in that school community at risk for transmission are things like close skin-to-skin contact. That happens in several situations in schools. For example, wrestling. So if a wrestler had lesions and were participating in practice or a tournament while they have those lesions, we could see transmission. But people who aren't sick or don't have symptoms, aren't at risk for transmitting this virus. So we ask individuals if they notice a new rash, if they notice symptoms that are consistent with monkeypox, contact their provider about testing, cover lesions, and go seek care. So we don't anticipate a lot of people showing up at school with lesions, but we are in the process. We're preparing some work on what schools should think about, what kind of activities would be at risk at school, which is fairly minimal. But then how can they support teachers and staff who might need to be out for 2 to 4 weeks if they are sick with monkeypox? How can they support a student with work at home for 2 to 4 weeks while that student recovers? And how can they try to control, privacy and anonymity in the school community, knowing that rumors will spread? How can they provide non-stigmatizing language about talking about monkeypox, talking about how it spread without revealing personal details about school community members impacted? Those discussions with schools are happening right now. We will have some resources in place for schools, but right now, parents should not have monkeypox at the top of their list of concerns about going back to school. School is a very low risk setting for transmission of monkeypox. We have not seen any children yet in Oregon impacted by monkeypox, but we will work on some resources for those settings.
Thank you for that question. Our next question comes from Daisy Caballero with KGW. Go ahead, Daisy.
I have three, hopefully a little bit shorter questions. My first question is, do we know how many tests have been administered for monkeypox or HMPXV?
Daisy, I do not know that. We could track down a number of tests that were done, I believe, at the Oregon State Public Health Lab, but for our community labs, many of these tests are done out of state. They don't report negative results to us. We only get the positive results, so I don't have the full picture of that. But as a corollary to this answer, let me say that laboratory capacity right now is not the limiting factor in getting tests done. It's the fact that this is a new disease, often with a subtle presentation, maybe around the genitals or the perirectal region that people may not notice. And so we really need people to be aware of their own bodies. If they're having symptoms, talk to a provider. And we need providers to ask questions about risk behaviors, to ask about rashes and other things so that we can do more tests. Yeah, two more.
Yes, thank you so much. I appreciate that. And now sticking with testing, do we know how long it takes to get those test results back from the day that they go in to get tested to when they do get the results? Do we have that time frame?
I think it varies by lab. We've not heard of long kind of turnaround times, but because of the specialized nature of the testing, many labs are doing testing twice a week and not every day. As volume goes up, I anticipate that may go up. I'm not sure if Dr. Lutke can add anything about the Lane County experience with testing returns, but I think it varies based on the lab, but we're not hearing huge delays.
I would confirm what you just said, Dr. Seidlinger. Depending on the lab, for example, Quest has said that their established published turnaround time is 3 days. Of course, that is dependent upon when the sample actually arrives in the lab that is doing the testing. Sometimes it takes a day or two to get there. We are not seeing any long delays, 10, 14 days like we have seen early on with COVID. It's usually 1, 2, 3 days. So far, so good. Of course, it can always be better.
And I will just add before your next question that we also, if someone appears to have monkeypox and would benefit from treatment, or we know some close contacts around them would benefit from post-exposure prophylaxis, we do not have to wait for those results to come in. We can initiate that treatment and provide those vaccinations before those come in. So Daisy, back to you.
Thank you both so much. And my last question, again, kind of making sure that the topic is anyone can get infected. It's not just a specific group. While it is right now, do we know how many of those individuals that have tested positive for this virus are part of the LGBTQ plus community or don't identify within that group? Do we know those numbers?
So our numbers here in Oregon mirror the national numbers, and it's well over 90% of our initial cases report behaviors that fall into some of those higher risk communities I talked about. So men who may identify as gay, bisexual, queer, or another name that they use, who report having sex with other men and may identify as straight. That's the vast majority of cases, well over 90%, that we've seen here in Oregon that's mirrored across other states. But that leaves, less than 10% who don't fall into that confined community or social network. And so everyone who engages in close skin-to-skin contact with others, whether during sex or during other activities, could be at risk if that person has monkeypox. So that's why I ask people, be aware of your own body and your symptoms. If you're sick and have a new rash, seek care from your provider and don't engage in these types of activities. Feel comfortable enough to talk to potential sexual partners or others that you're going to have this close contact with about their symptoms. Are they sick? Are they having a rash? And avoid having those activities during that time. And that will help us control the spread of this disease, along with efforts like vaccinating in those highest risk groups and other groups as it comes on, and treating folks appropriately with TPOXX and other wound care.
Thank you for those questions, Stacy. Our next question comes from Brandon Thompson with Coin 6. Go ahead, Brandon.
Hi there. I also have a two-part question and then a follow-up question. Again, on testing, we've heard from a couple people who have contracted monkeypox who said they had to convince their doctor to test them. One of the reasons one doctor gave is that there is a pretty arduous system through the public health department to submitting those tests and filing that kind of paperwork. Part one of this question, is OHA working to break down those barriers to reporting testing and motivating more doctors to test their patients? And second part, what should be the threshold for doctors in testing patients?
Thank you. Let me say first that our system for ordering testing for monkeypox or MPXV has changed. Initially, when there were a few cases, testing was limited to public health laboratories. A consultation with public health and permission to send in the test was required. That is no longer required. If a clinician suspects that the person in front of them has monkeypox, they can order that test through their routine commercial labs that they normally use, or through the Oregon State Public Health Lab, without needing to talk to public health. A few things about this test. This is not a nasal swab or a throat swab. This is a swab of the lesions. So someone needs to have symptoms with the rash in order to be able to swab those lesions and send into the laboratory. We want people to have a low bar, and we know that changing behavior can be difficult. But this is a relatively unseen virus in Oregon. Most clinicians have not seen a case of monkeypox. The rash can be subtle in some individuals, may only be a few bumps, may be more extensive. And may exist in parts of the body, around the genitals, around the anus or butthole, that aren't typically included in a physical exam. So we ask providers to have, a low suspicion for ordering this. If they see someone with a new rash, even if they don't report being in one of these high risk groups, swab those lesions, order that test, and appropriately counsel their patient. We continue to have conversations with providers to get this message out. And we'll continue to do that.
Members where it was very difficult for them to access care. They had to go to multiple different providers to get the answers that they needed. So yes, I have heard of that in the community.
Thank you for those questions. All right, our next question comes from OPB, Amelia Templeton. Go ahead, Amelia.
Yeah, I have a couple questions. First, just a brief one. Do you have the numbers on how many people are waitlisted for the vaccine currently?
I do not. Those are held primarily by our local public health authority partners and others, and I know there have been varying sizes of wait lists. With more arrival of vaccines in the state as part of our latest allocation, we're starting to really work through some of those wait lists, and with hopefully changes coming next week in our dosing strategy, being able to use intradermal vaccination rather than subcutaneous vaccination, we can get 5 times as many vaccines out, but I don't have a definitive number of that. That's something OHA collects. Got it.
And thanks for mentioning that strategy change. I've been wondering about that too. Second question, do you have data on, of those cases, in how many cases it was sexual contact or sexual behaviors versus other kinds of skin-to-skin contact that transmitted the infection?
Thank you. I don't have the definitive number, but I would say the vast majority, again, well over 90%, have reported sexual contact with another individual. Sometimes those individuals have had symptoms or have later gone on to have a diagnosis of monkeypox. Other times they have not, but we've seen those histories reported in almost all of our patients.
There's emerging and in no way resolved science around the possibility that this virus is transmitting asymptomatically, and that it may also be transmitting not only through skin-to-skin contact, but potentially through more traditional sort of STI, strictly through sexual transmission as opposed to skin-to-skin with a lesion. Do you have any message on, and that really, for people who are trying not to get it, those are sort of important distinctions. So is there anything you can say about your understanding of that science and about what people should know about either asymptomatic transmission or sexual transmission?
Thank you for those questions. Let me start by saying, as a public health official, I need to be extremely humble as we talk about monkeypox, as we do about any other emerging infection, because we are continuing to learn new information. We'll continue to adapt our messaging. Certainly, let me start with some data that you asked about. In the laboratory, it has been demonstrated, I believe, that the monkeypox virus can be isolated from sperm. So it could be transmitted in a sexual way. It may also be that individuals have lesions in the perirectal or in the genital region that may be unnoticed, that may be transmitting the virus. So certainly, I think it could be truly transmitted in a sexual way rather than just during sex, and we'll continue to learn more about that. There is some laboratory evidence of folks who did not report symptoms, who had virus isolated from bodily fluids, or evidence of infection from bodily fluids, but we're not seeing evidence of transmission from people without symptoms during this current infection. So we'll continue to study that, but we don't think this is going to be a case that people without symptoms or people with just kind of limited contact, for example, on a bus or in a store, could transmit this virus. What we're seeing is it requires this close, intimate, or sexual contact. We're not even seeing significant transmission amongst household members, so that does happen more commonly. But this does seem to require individuals who are sick contact with skin and lesions from those individuals. But we'll certainly try and look to see what else might facilitate this, because we're learning more every day and every week.
Thank you for those questions, Amelia. Our next question comes from Fedor Zarkin with the Oregonian. Go ahead, Fedor.
Hi, thanks for taking my several questions. So of the 95 cases, how many have not been connected to other known cases?
Yeah, I don't have the information on direct connection of cases to others. We have oftentimes we get information on risk behaviors, but not necessarily individuals, or can we connect them to cases, but I don't have that data.
But that would be indicative of community spread, presumably.
Correct. And we do have community spread here in Oregon. Our initial case, we had very good interviews that the person had kind of high risk exposure outside of Oregon while traveling. When they came back to Oregon, had very limited close contact with others, and we did not see any transmission on. But within a few cases, we weren't able to make that direct connection to an individual or behavior, and we knew that we had community spread. Again, for several individuals, their symptoms are minor, and they may still be able to, transmit to others when they're feeling okay. And so, yes, there is community spread here in Oregon, and we're not going to be able to trace all cases back to another case or a specific instance.
Thank you. And then, is this virus going to become endemic in Oregon? And also parallel to that, what does Oregon OHA modeling show will be the peak and when?
So let me start with endemic. I think we are definitely going to be facing this disease and see this disease circulating in our community for some time, months to potentially years. We hope that with getting information out about what are the symptoms, what to look for, when to seek care, what behaviors put you at most risk, getting vaccine out to broader groups of people as it becomes more available, from the manufacturer down to our federal partners and to us, that we will be able to control this. But we will be facing this for months, if not years. As far as modeling, OHA has not done any specific modeling, but we're in contact with our Centers for Disease Control and Prevention partners, as well as our neighboring states, and talking about those issues. We anticipate some modeling coming from the CDC that will get down to the state level, that will focus on the communities we're seeing at risk now, and how it might spread over the coming months. Those models should be available within the next couple of weeks, and we'll continue to work with our neighboring states to see if we can refine that process once those models come out. But in a couple of weeks, we should have an idea of some at least short-term projections from our CDC partners.
Got it. Okay, thank you. And then how many vaccines are scheduled to arrive in Oregon, and when? Doses?
I will have to follow up with you on, we are currently in the second part of tier 3. And so we have a few thousand vaccines available, but I will have the team get back to you with the exact number of what's still available to us to order. And that will change, because when we start using an intradermal strategy, many of those doses can be used to vaccinate 5 individuals. So that number may be a little complex in giving it to you.
Okay, and last question. So does the state, is the state going to be providing services to individuals for whom isolation is a hardship, or counties?
I think the state, our local public health and community-based organizations are working on a case-by-case basis to get people what they need. There are limited resources out there to support isolation for individuals in public health budgets. This is not like COVID-19, where we have dedicated federal funding to support individuals in isolation. Certain groups, people living with HIV, can access housing and some other sources that may help them if they become infected with monkeypox. And there are certainly other resources that we try to link people with. But as you heard from Katie Cox, we do not have nearly the resources we need to support everyone who would have to isolate for 2 to 4 weeks following this infection. That would include help potentially with housing, with food, pet care, child care, and other things. And so we're actively looking for additional resources and hoping for flexibility in some of our funding that we have, that we can do more of that support.
Thank you, Fedor. All right, I'm going to cut you off right there because we have another reporter who has yet to ask a question. Elizabeth Hayes with Portland Business Journal is up next. Go ahead, Elizabeth.
Thanks. Dr. Seidlinger, I was wondering if you could just go over the vaccine dosage numbers again. I just want to make sure I got that straight. How many have come in? How many distributed? Then you said something about 35 left with partners. I wasn't clear on, so how many exactly are, you are able to distribute like pretty quickly without more supplies coming in?
Yeah, so the 3 numbers I would focus on is that we have received 6,803 doses of vaccine in Oregon. That's vials counted as single doses. We have documentation that 2,187 have been administered, and that documentation has occurred in the Alert Immunization Information System. And we know that many vaccine clinics have happened in the last few days, and those doses have not yet been entered in. The Oregon Health Authority has 35 doses in stock to meet immediate needs. That doesn't mean that there aren't other vaccines to meet immediate needs that are pre-positioned in other counties with healthcare systems and organizations that aren't spoken for in their current clinics, but that are ready and available if a public health department or a healthcare provider needs those vaccines. But 6,803 doses received in Oregon, documented 2,187 doses given, only 35 in OHA inventory.
Thank you for that question. Okay, we have a couple follow-ups, and then we have, let's go next to Lynn Terry with the Oregon Capitol Chronicle. Go ahead, Lynn.
Yeah, hi, thanks. So I'm just wondering about, you mentioned, Dean, about switching to intradermal next week. I'm wondering why, since the Biden administration already recommended it, why you didn't start immediately. But then also with that question, I've heard from an infectious disease expert that they don't really know how efficient that, giving a shot intradermally is. So kind of two questions there. Thank you.
Thank you for that question. So let me start with, OHA, our local partners, our federal partners, are looking at all the data we have to try and make decisions about responding to the situation in front of us, which is changing, week by week. In a prior study with Jynneos vaccine, they looked at doing this intradermally, meaning just under the skin, versus subcutaneously, which is slightly deeper, and the traditional method for vaccine delivery. What they found in that study is that following 2 doses of vaccine, antibody levels against monkeypox virus were similar amongst intradermal and sub-Q administration. The reasoning behind that is our skin, in addition to being a great barrier at preventing infections from entering our body, has amazing immune cells in the body, and it's thought that by injecting them not so deeply into the skin allows those cells to perform their duty better and provide a similar response. So that's the data that we're using to make this change. The Food and Drug Administration put out this authorization earlier this week, and we are in the process of updating protocols, assuring that we have the vaccinating staff available who are comfortable with intradermal vaccines, have the skills, and can do that so that we can vaccinate people appropriately. It may slow down the administration of vaccines, as it, particularly this is not a technique that's used as widely. And so we anticipate that some of these initial vaccine clinics where our providers, our nurses, and others are using this technique, that it may go a little slower. So we're just in the process of updating everything to make sure we have the appropriate and skilled staff, the ordering information, the other things that support this technique, and we anticipate being able to make that switch over definitely by early next week. There will still be some populations, children who may be exposed and may be getting this vaccine because of risk factors, will still get a sub-Q dose of vaccine, and so we'll maintain those orders and the ability to give that to individuals.
Great, thank you for that question and thoughtful answer, Dr. Seidlinger. We have quite a few follow-up questions, and in the interest of time, we'd like to wrap pretty soon. So I'm going to call on next Amelia Templeton. You had a follow-up? Go ahead.
Yeah, I have a follow-up for Dean and a follow-up for Katie. For Dean, can you tell me anything OHA has done to specifically communicate with the Hispanic LGBTQ community and to specifically target vaccine or treatment to the Hispanic LGBTQ community or other members of the Hispanic community engaged in high-risk behaviors?
Thank you for that. I think, one thing we've done is we try to simultaneously, or at least with little delay, translate our public-facing information into Spanish so that that information is available to individuals. We have several groups that we brought together amongst our community-based organizations that we've partnered with and contracted with, who specifically address the Latino, Latinx community, and LGBT population specifically within that community. As we know that having a trusted voice who's grounded in the community, has relationships, is going to allow us to reach out better in a community that may feel marginalized from public health or the healthcare system for multiple reasons, whether it's language, culture, documentation status, sexual minority status, or other things. And so we hope to continue those partnerships. We need to, evolve more materials and outreach materials into that group. We've done with our local public health and community-based organization partners specific outreach when we've identified cases in the Latino population and communities to reach out to organizations that serve those groups, healthcare providers who serve those groups, so that people can get messages about who's at risk, what activities put you at risk, so that people can get tested, get treatment if they need to, and we can get vaccination out to that group. 30% of our cases are reported in folks who identify as Latino, Hispanic, Latinx, and that is much more than they're represented in the Oregon population. So we need to continue a focus on getting information out to them that's accessible by language, by the person delivering the information geographically, and we have a lot of work to do.
And then I just wanted to give Katie kind of a chance to weigh in on that as well. If there's any, what you see as the kind of missing bridges or missing prevention work to be done to drive those numbers down among that specific community.
Yeah, I mean, all of the things that Dr. Seidlinger mentioned, I know that we facilitate a community health program with community health workers. We have a couple of bilingual community health workers that are going to be working on translating some materials and doing some very targeted outreach. And also seasonal farm workers, I think, is another area that we want to tap into. So it's definitely part of the conversation.
Thank you for that question, those great questions and wonderful, thoughtful answers to our speakers. Okay, we have 2 more follow-up questions. Brandon Thompson with Coin6 has a follow-up. Go ahead, Brandon.
Yeah, just given that the FDA is considering splitting doses, does OHA have a stance on that? Yeah, is that something they're considering to extend the supply of vaccine that currently is in your guys' possession?
Thank you for that question. You know, as I mentioned in a previous response, yeah, OHA is updating our protocols, ensuring that we have trained vaccinators who can deliver an intradermal dose of this vaccine. A small study showed that intradermal delivery of the vaccine at a dose 1/5 that is of a subcutaneous dose offers similar levels of antibody response in the body. So by using this technique, we'll be able to give 5 times as many vaccines with the supply we have. Children under 18 who get vaccinated will still get a subcutaneous vaccine. Individuals who have issues with keloid or really severe scarring following injuries may also still continue to get a subcutaneous vaccine, but the vast majority of the people will have similar levels of protection with 1/5 the dose, and we'll be able to get 5 times as many people towards protection from monkeypox.
Thank you for that follow-up. Okay, our final question comes, again, a follow-up from Daisy with KGW. Go ahead.
Erica, thank you guys so much. I appreciate it. Last question. So I just wanted to make sure that I got the percentage right. Early on, we spoke about the Hispanic population being the most affected group. Is that accurate to say? And what was that percentage again, just to make sure?
So currently, 28.4% of our 95 cases identify as Hispanic or Latino. So they do represent almost 1/3 of our cases here in Oregon, and that mirrors national numbers where they represent a similar proportion, and that's more than their percentage in the population. So they do seem to be getting this, or at least being identified as having monkeypox at a higher rate. So we need to continue a focus to try and prevention messages, get folks in for treatment, and to stop the spread in this community. With that, I want to thank you for your attention. You know, for Oregonians out there who are tired of hearing about outbreaks, whether it's COVID-19 or something else, I want to reassure you that while this is a very serious public health threat, it does not spread very easily like COVID-19 or other respiratory viruses. Right now, the best thing you can do is to know your body, know symptoms. If you're feeling sick and have a new rash, talk to your provider, seek care, and get tested for this virus. There is treatment that we can offer you. If you're a gay man, bisexual man, another man who reports having sex with men, these are communities and social groups where we're seeing spread right now in the vast majority of our cases. So having prolonged skin-to-skin contact, whether through sex, other intimate acts, or other ways, is what puts you at risk.